Thank you for listening to this PYA webinar recast. PYA is pleased to offer this alternative way to access our thought leadership. This is a recording of a previously delivered webinar. The information is accurate as of the date of the original event. The video recording, slides, and associated material for this and all PYA webinars are available on our website at pyapc.com. This podcast is for educational purposes only. It is not intended to be used as legal advice or an official opinion.
Good morning, everyone. Welcome to today's episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is Washington Updates, Fiscal Year 2026, First Day, Fresh Questions. PYA is happy to present today's webinar on this important topic. With that, I would like to introduce our presenters, Martie Ross and Kathy Reep.
Thank you, Jennifer, and Happy New Year, everyone. Although I'm not so sure.
Last night were amazing.
What? I'm sorry?
The fireworks last night were amazing.
They were great, weren't they? Exactly.
Yeah.
No, there were no fireworks because the government shut down.
That's
exactly. Right. I just want to blame Kathy for this one because on our normal schedule, this webinar would have been last week. But she said, oh, no, let's wait till October 1st so we can talk about the continuing resolution and what they did to prevent the government shutdown. Mm-hmm. Great crystal ball there, Kathy. But
right.
as you all know, as of 12:01 Eastern, the federal government is shut down. We're going to talk about the impact that has on healthcare. We're going to discuss today the Rural Health Transformation Program application process, which is still in full swing. Congressional hearings on nonprofit status for hospitals. Those were there've been two of them. We're going to talk about what we think is going to grow out of that in terms of legislative initiatives. The HB1 visa fees and the controversy surrounding that. And we'll wrap up with some updates on pharmaceutical tariffs. That's pretty aggressive, but Kathy, tell us all about it.
Sure. And before we go any further, let me clarify the record here. What I said in terms of not doing it last week, but doing it this week for this webinar was that by October 1, we would know something one way or the other. We wouldn't have last week. So clarifying, we do know something is not much. So let's just go with the big picture. We're closed. So why are we closed? Essentially what we're looking at is, we've talked a lot about the One Big Beautiful Bill Act, and that was a reconciliation bill that was addressed a lot of with Medicaid, et cetera. But annually, there are 12 appropriations bills that must be addressed in order to keep funding the government. As of midnight last night, no appropriations bills had been finalized. None of the 12 had been finalized by the House and passed over to the Senate. So what the House did was they passed a continuing resolution to keep the status quo through November, up to November 21st, I believe was the date. And then, but the Senate did not agree to that, and therefore it was not passed. There was another vote taken yesterday on the same bill. Senate voted on it again. Actually, two more Democrats voted in favor of the continuing resolution than had voted previously. So we don't know if we're going to be looking at this whittling down of getting another one, but we do have to have the majority moving us forward. Actually, 60 votes, right, Martie, to push it down. We're right at 55-45 now, if I remember correctly, 55 in favor of the continuing resolution. So with the idea that we are closed, what does this mean, and what in particular does it mean for the providers? First of all, because Medicare funding is mandatory, Medicare funding is not impacted by the shutdown. We're going to talk about what could be impacted from the Medicare program perspective as we go through this. The Medicare administrative contractors are going to continue processing claims, processing payment. Very likely we're going to see some slowdown on a certain programs such as audits, reviews, things like that. But we also, and we're going to talk about workforce, we also are looking at the fact that about 50% of the CMS workforce is expected to be furloughed as of today. Notices went to folks saying that individuals would be furloughed. From a claims payment perspective, you're going to see that we're going to talk about several provisions that basically CMS is going to hold claims for 10 days with the expectation or the thought that maybe things will be resolved by that. But with that holding claims for 10 days, that's still within the 14-day payment floor. Therefore, it should not impact payment moving forward. But when we're looking at an item that they're holding the claims, it would be to determine what level of payment would actually be made on day 14. So I'm going to talk about some specific programs under Medicare. But before I do that, let me just mention under Medicaid, essentially the Medicaid funding is expected to be sufficient to get the states through the end of the first quarter, which would take us up until January. So let's look at those provisions that were included in the continuing resolution and what now, as of today, are expired. Hopefully they will come back. Medicare dependent hospitals and low volume hospitals, CMS has indicated that they will hold their claims for 10 business days. What we saw during the 2018 shutdown was that the hospitals were made whole following the ending the shutdown, but payment will be made. It just would not be made at the current level absent the shutdown ending within the next 14 days. Community Health Center Fund, again, the federally qualified health centers will continue to be able to access Section 330 grant funding. And historically, the Community Health Center Fund dollars available, it was retroactively reinstated again following the 2018 shutdown. The work GPCI or geographic practice cost indice that is set at a floor of 1 and rural ambulance add-on payments, again, holding claims for 10 days. And then claims will be paid on day 14. But the question is, will they be paid at the current level that they're paid at? Medicaid disproportionate share, we remember that under the One Big Beautiful Bill Act, or as Martie affectionately says, OBBA, and I am beginning to like OB3 because of Star Wars, but the cuts were not included in the final version of the bill. Therefore, we are looking at a $32 billion reduction over 4 years in Medicaid disproportionate share funding. This, in the continuing resolution, kind of took the wind out of OBBA's sails and essentially said, let's push it down the road in terms of making any reductions to that program. Now, with the shutdown, essentially we are saying, or CMS is saying, that it is up to the individual states in terms of whether they make the payments for this quarter and the funding that the individual states have. Again, historically, this was brought back to whole once the shutdown ended. Hospital at home, major area of concern for those providers that have hospital at home programs. CMS essentially instructed hospitals with Medicare approved waivers for hospital at home that all inpatients, remember these are inpatients, but they are being treated in the home, not in a hospital setting, that all inpatients needed to be discharged or returned to the hospital as of yesterday. And so again, those patients should not be being treated in the home right now. They should either have been discharged or they should be being treated as an inpatient in a hospital bed. Martie, what about telehealth?
Well, what you were discussing, Kathy, up until the hospital at home, are programs where we've been there, done that.
Been there, done that.
Right, because in the 2018 shutdown, which lasted for 35 days, we know what happened in the legislation that brought that shutdown to an end and how it treated those different programs. But hospital at home was one of the COVID waivers, and we don't have precedent on what happens going forward. And that is also true with respect to the Medicare coverage waivers for telehealth that date back now to March 2020. In March of 25, as part of the continuing resolution that kept the government open through yesterday, Congress had extended those different programs that you discussed, but they also extended these telehealth waivers. But because the government has shut down and those waivers have now expired, let's look where we are in terms of Medicare coverage today. Because of the Consolidated Appropriations Act of 21, we now have permanent Medicare coverage for telebehavioral health services that are furnished to a beneficiary in their home. And those services can be billed by physicians, practitioners, as well as rural health clinics and FQHCs. What goes into effect now for individuals who are for the first time being seen via telehealth is the requirement that there must have been a face-to-face visit within 6 months of the initiating telehealth visit. The exception there is that requirement has been delayed till January 1st of 2026, but only for RHCs and FQHCs. But for everyone else who's looking at providing telebehavioral health services to new patients, patients you've not previously seen via telehealth, you now have that face-to-face visit within the last 6 months. If you already have an established telebehavioral health relationship, if you started providing services during the waivers, there's no requirement that you now have a face-to-face visit. It's just new patients. The big kicker, of course, is Medicare telehealth services will now be restricted to a beneficiary who is physically present at a facility located in a rural area. So we are going back to the pre-COVID rule. So no longer can provide for telehealth, not for medical telehealth services furnished to a patient in their home. They have to be physically present at a facility. So a hospital, a nursing facility, a rural health clinic, and the like. Appreciating that, we'll go on in more detail there. So all that coverage we had for medical telehealth services has now come to a crashing halt. In addition, the waivers that allowed physical therapists, occupational therapists, and speech language pathologists to bill for telehealth services, that waiver has expired. So no additional claims from those providers for telehealth services. Through the end of this year, RHCs and FQHCs will still be able to bill for medical telehealth services under HCPCS code G2025, but appreciate they're only going to be reimbursable if those services were furnished to an individual who's physically present at a facility at the time the service was delivered. So yes, an RHC and an FQHC can still be an originating site, a distant site. I mix my telehealth terms. So it could be a provider at an RHC or an FQHC who's delivering services via telehealth, but only to an individual who's physically present at a facility located in a rural area. So not much of coverage left there. Then on a permanent basis, Medicare telehealth services now can be furnished audio only if the beneficiary is at home when the service is provided, the practitioner is capable of audio-visual connection, and the beneficiary themselves does not want to connect via video. Again, that means for practical purposes, there's no longer any audio-only medical telehealth services because you can't provide medical telehealth in a patient's home, but you could provide telebehavioral health services via audio only if you met those requirements. So we no longer have the code list that determines what services can be provided audio only, which cannot. We now just have this test. This morning, it showed up in many of you may have received in your inboxes an announcement from CMS regarding the shutdown. specifically addressing coverage for telehealth and what happens now. And CMS's advice is that practitioners who choose to perform these services, which are now not payable by Medicare, may want to consider providing the beneficiary with an advanced beneficiary notice of non-coverage. And then they direct you to continue monitoring congressional action. You may choose to hold claims associated with telehealth services, which may not be payable for Medicare. So here's the choice you have to make. If you continue providing medical telehealth services to individuals in their home, you can, in advance of providing any future services, provide the beneficiary with an advanced beneficiary notice of non-coverage, which would then allow you to bill the beneficiary personally for those services. If you bill the patient personally, you give up the right to submit the claim later to CMS. Or you provide the service, hold the claim, don't submit it yet, because if you submit it, it's going to be denied. If you hold the claim, you're betting that whatever legislation eventually gets us out of this shutdown will retroactively apply the waiver, meaning that a service that you provide today would be billable at some point, would subsequently be paid if it was submitted later. You got a year, right? Sorry, Kathy, go ahead.
I was just going to say, with that, if you do choose to go ahead and bill, and you get a denial, then you're going to have to go through the process of reopening and appealing that denial, et cetera. So again, it's something that you need to look at your practices on and make sure, do you want to sit on this for a little bit, or do you want to have to go through rework after the fact?
Okay, and just again, 3 options is provide the service, provide the beneficiary with an ABN, bill the patient for the service because it was a non-covered Medicare service. That's option 1. Option 2, submit the claim, but appreciate it's going to submit the claim now, appreciate it's going to be denied. And as Kathy noted, then your remedy is going to be taking it through an appeals process. Option 3, hold on to the claim. You can do that for a year, but hold on to the claim, hoping that whatever congressional solution we end up with would be retroactive back to October 1st. So
and if you choose option 1, which is to provide the ABN to the patient, and you bill the patient and the patient pays, when this is hopefully addressed retroactively, you're going to have to refund the patient and bill the Medicare program. Because if this is fixed retroactively, then there was coverage when the services were actually rendered, if they do it retro.
Correct. So this is one of these times I have to say, don't shoot the messenger. We've known this. We've been on this clip before, and finally we've been pushed off it. And that's where we are today in terms of Medicare coverage. Kathy, your turn.
Sure. Is there any light at the end of the tunnel? Yes, it's an oncoming train. But just so that you know, in order to end the shutdown, it does take 60 votes in the Senate to pass legislation. They keep revoting on what they voted on a week and a half ago. They voted on yesterday, as I mentioned earlier. The number of votes in favor have increased a little bit, I think by 2. We're going to see where it goes as we continue going through this process. But my understanding is they are voting again today on the same legislation. There are demands from the Democratic leadership perspective. One relates to the ACA enhanced premium tax credits and whether or not those would be extended beyond the end of the calendar year, and then also to reverse the OBBA Medicaid cuts, and then finally limiting the administration's ability to rescind or reallocate funds approved by Congress. So essentially what we're looking at here is 3 provisions that the Democrats want to have tacked onto this. The Republicans are saying they aren't part of a continuing resolution. It's something we will look at separately in additional legislation. So here we go. So that was what they included in their September 19th request. Now they're really just focused on the premium tax credits. Again, they expire at the end of the year. The other issue, and this was not addressed in the legislation that, in the continuing resolution, is we still need some action between now and 14 days after the end of this session of Congress, which will be sometime late December, I presume, because absent action to stop the requirement from the Congressional Budget Office of increasing sequestration from the current 2% to 4%, we would be facing a 4% sequestration reduction at the beginning of the year. Martie, did you have something to say on that?
I was just going to note on the ACA enhanced premium tax credits in the context of discussing OBBA and its the impact it's had on the ACA exchanges in terms of eligibility. We've talked about the potential impact of the sunsetting of these enhanced premium tax credits at the end of the year. And CBO has looked at that, and it's 4 million additional uninsureds are anticipated as a result of this. And there's also the impact it has on the commercial market more broadly, because now you're starting to see the reports coming out about increases in premium rates across all product lines as a result of this, as insurers figure out how to balance it. So it's just a challenge in every way imaginable. And we'll see how this one goes forward.
And just, I guess, let's add one more thing on top of this. Essentially, the White House, number one, has circulated a memo to all the federal agencies directing them to prepare what's called an RIF, or a reduction in force plan, for mass firings during the shutdown. Normally what we see is furloughs. We are going to see furloughs. We're going to see furloughs of certain within certain departments, but we're also going to see, based upon what was called for by the White House, firings of individuals with the goal to reduce the overall size of the federal workforce. We're probably looking at, within HHS itself, about 32,000 of the current 80,000 employees would be furloughed. We don't know if there are plans, if there's any recommendation that has been made regarding terminations within HHS. I think we mentioned earlier that about 50 to 53% of the CMS staff will continue to be working during this process. If it is a program that is not directly funded by OBBA, essentially, or which includes immigration enforcement defense programs, if it is not a mandatory program, then that's where we're going to begin to see some of the workforce reductions. And just to add on top of this, recognize that today, October 1st, is the beginning of the federal fiscal year, and all of those employees, about 150,000 federal employees who took buyouts that were offered during the early part of the year under the DOGE recommendations. Those individuals, 150,000, yesterday was their last day at work. So we've already reduced the workforce by 150,000 as of today, just because of the buyouts.
Kathy, how many of those are in CMS?
Somewhere a little over 300, but I'm just concerned that those are the 300 who really know what's going on, because they're probably the ones with more background, more history. They've been there the longest in terms of getting the buyout. So concerning in terms of, do we lose knowledge?
Yeah, probably the people who were there in the last during the last government shutdown in 2018 for those critical 35 days. And speaking of days, we have a polling question.
A test.
So we'll just get the mood of the audience here. And how many days do you think the shutdown will last? 1 to 5, 6 to 10, 11 to 20, 21 to 35, it will beat the prior record, be more than 35 days, or for the true pessimists in the group, it will never end. So if you could please vote, we'd love to see what folks are thinking.
We have a handful of, you said pessimists, maybe they're optimists, I'm not sure which, related to it will never end. Handful of those.
It's pretty evenly split, though.
Yeah.
I think 11 to 20 seems to be a popular pick, but we shall see. I don't have a crystal ball on this one of what's going to go forward.
Very, all to you, Marty.
Okay, well, let's shift gears. Let's talk about something a little more positive and talk about the Rural Health Transformation Program application process, which is now in full swing through November 5th. And if you recall, in OBBBA, there was created a $50 billion Rural Health Transformation Program to distribute funds to the states at a clip of $10 billion a year from FY2026 through 2030. We knew, based on the statutory language, that this would be monies that would be distributed to the states, not to providers themselves. And then the states would be responsible for distributing that money consistent with an approved rural health transformation plan. What happened on September 15 is CMS released the formal Notice of Funding Opportunity, which we lovingly refer to as the NOFO. And the NOFO provided the detail with regard to CMS's intentions for distributing the money, and specifically what states would have to develop in their applications so that CMS could make those funding decisions. So here's how it works. There's a total pool of $50 billion that has been divided into two tranches. Tranche 1 is baseline funding. Tranche 2 is workload funding. They are equal, both at $25 billion. The baseline funding will be distributed with $5 billion available for distribution each budgetary period each year. And that will be equally divided among the states who submit an approved rural health transformation plan. So they submit their application and it's approved by CMS. That's equal. So if all 50 states submit a plan and it's approved by CMS, every state's going to get baseline funding of $100 million a year. Well, that's how much would be available for potential distribution. The other half of the money is going to be distributed based on factors. And there are 3 types of factors that CMS will utilize in calculating those scores. The first category of factors are rural factor data, as they refer to it here. These are, and we'll talk about what these factors are, but these are objective data-driven points. And a state score on those factors will be determinative of 50% of its overall relative score for purposes of the workload funding. The second type of factor are state policy factors. And these are whether a state has adopted certain policies, which CMS identifies as key to rural health transformation. And the state's score on those factors will account for roughly 15% of a state's relative score. And then finally, there are the initiative-based factors. These are really the core elements of a state's rural health transformation plan. And these are tagged initiatives that the state develops, explains its implementation plan and the like. That's going to tag roughly the remaining 35%. A state can then use of the dollars it does receive, it can use up to 10% of that for administration. And a state must expend all funds received within a budgetary period by the end of the following fiscal year. Specifically, they tag October 31st. So it's actually a fiscal year and an extra month. So if you receive money in January of 2026, all the funds have to be expended that you've received by October 31st, 2027. For purposes of providing a budget as part of its application, states have been instructed to assume they will receive $200 million each year for 5 years. CMS says, of course, there'll be adjustments made for those states that receive less, those states that receive more. I love there was a headline in Politico when this was announced, and they referred to it as the Rural Health Hunger Games, because now the states are all competing against each other. There's no alliances per se because of these factors in the workload funding. Let's drill down a bit more about how then CMS will score the factors. There are 23 of these factors. Again, each are assigned 100 points, but they have relative weights. And then a state's total point score will then be compared to other states for purposes of determining how much they receive each year. The rural facility and population score, those objective scores, CMS is going to score one time in Q4 of 2025. That score remains constant. The other factors are reassessed annually, and that will determine how much of the funding that the state received will it actually be able to have delivered to it in that upcoming fiscal year. Briefly, let's run through those rural facility and population score factors. There are, again, 7 of these. And as I said, they're completely objective. It's like, what's the area of your state in square miles? There's not much you can do about that. We did talk in Kansas here about annexing eastern Colorado to increase our score, since everyone really can't tell the difference between western Kansas and eastern Colorado, but they didn't go for it. So that's just a number. This is all, again, CMS is going to use available data it has for purposes of calculating these, with the exception of the percentage of hospitals in your state that receive DSH payments. As part of its application, the state has to identify the number of hospitals that received DSH payments in its most recent rating year. Next up, just for fun, this is a slide that was actually produced at the National Rural Health Association's annual Critical Access Conference last week. This is analysis done by the University of North Carolina. This is their estimation of how those factors will score across states. And so you'll see that North Carolina, interesting, right? UNC did the study, and North Carolina has the highest score, all the way down to Rhode Island. I guess they have the highest score, and Rhode Island has the lowest score. So to kind of give you a relative feel of how that 50% of the workload factor may shake out based on available data. As I referenced, there are 8 state policy factors that come into play. And so the state will be scored on where it stands with regard to these policies. And so just an example, the first one is a health and lifestyle factor, and they're not counted in 2026, so you have a year to ramp up. That factor is, does the state require schools to establish the presidential fitness test? The SNAP waivers, has the state received a USDA waiver to prohibit the purchase of non-nutritious items with SNAP dollars? And yes, they do define what constitutes a non-nutritious food within that state policy. Nutrition, continuing education. Does the state require physicians as part of their annual continuing medical education to include a segment on nutrition and how to counsel patients about nutrition? Then the next is whether your state has a certificate of need program, and this is a sliding scale depending on the different types of facilities that your state submits to a certificate of need program. Your state's participation in licensure compacts from physicians, nurses, EMS, psychologists, and physician assistants. Scope of practice, whether your state has authorized these individuals listed here to practice at the top of their license. Whether the state places additional restrictions on short-term limited duration insurance beyond what was specified in federal guidance. And finally, in the issue of remote care services, whether your state Medicaid program is reimbursing for telehealth and remote patient monitoring, and whether your state has adopted licensure rules that are friendly, shall we say, friendly to the delivery of telehealth, which of course you don't get reimbursed for now, but we won't go there. The state will afford you the opportunity. A state has the opportunity, if it doesn't have a policy that aligns with those factors, you can represent in your application as a state that we're going to change policy, and you can get partial credit for making that commitment. But if you don't get the job done by the end of 2027, or with respect to 2 factors 2028, CMS is going to recoup the money it gave you based on your representation that you would change the policy. So you better be serious as a state if you're planning to make those representations of potential changes in policy. As I mentioned, the other 35% of this workload score is tied to initiatives. And appreciate that these initiatives are really playing 2 jobs in this application, because these are the initiatives that CMS says you can spend your money on. Right, so these are the elements of your state rural health transformation plan, but also the quality of your initiatives that you propose will then be determinative of the amount of money you receive on workload funding. So this is really where, as folks saw the NOVA when it was published, appreciated that this program is going to be far more prescriptive than we had anticipated. That really CMS was giving us specific lanes where it wanted to see its rural transformation plan. So let's review these 10 briefly. And the first being population health clinical infrastructure. So what's the state's initiative to address population health and to build the infrastructure necessary for management at the population level? And really this is, as you see here, just 3 bullet points briefly summarizing the NOFO definition of what constitutes these types of initiatives. Second are health and lifestyle initiatives. And you'll see here that while the other initiatives are scored at 3.75, this is scored lower because a portion of that 100 points that are assigned to each factor are assigned over to state policy. Remember, we talked about health and lifestyle and the implementation of the presidential fitness test in schools. So this one's, as an initiative, is worth a little less, but this is prevention and wellness, both primary prevention, so keeping people healthy so they don't develop chronic conditions, and then also secondary prevention. Once an individual has a chronic condition, how do we prevent that from becoming more severe? And with a particular focus here on engaging multiple stakeholders as well as community resources to address these needs. Number 3 is rural provider strategic partnerships. And this is really as broad as you think it is. This is how do we expand access to specialty services in rural communities? How do we build a continuum of care so folks are all working from the same best practices, implementing care coordination, and especially the use of remote services for those care coordination activities? Is there an opportunity to help rural hospitals that are struggling financially by centralizing and streamlining back office functions? How do you otherwise improve the financial viability of providers, and specific emphasis here on keeping care local? And then addressing right sizing hospitals, or converting those hospitals that may now be a critical access hospital or a struggling PPS hospital to the rural emergency program. And again, these are just examples. The language in the NOFA is relatively broad here regarding these types of initiatives to be included in the plan. Number 4, is EMS, and it's really transportation more broadly, is how do we build infrastructure to ensure individuals, when they need to be transported between facilities, those services are available. How do we now create infrastructure for treatment in place? For example, when EMS comes out and picks you up, if they provide any care they provide at that point is not separately reimbursable. They're still just reimbursed for mileage. So this is the idea of, can we create models where via telehealth, EMS can consult with a physician, and that provides that opportunity for reimbursement to encourage that treat in place type of model. Number 5 is talent recruitment or workforce. How would you use funds to secure a stronger rural workforce, all the way from physicians down to other staff within the hospital, technicians, certified medical assistants, certified nursing specialists, and the like. Sort of, how would you expend funds to stabilize a rural workforce? Number 6 is interesting. It is actually within each state Medicaid program, creating alternative payment models to provide incentives for providers to improve quality of care, but also to reduce total cost of care. And as part of these initiatives, CMS wants to see the state Medicaid programs moving towards risk-based models, and hoping that that incentivizes then providers to develop those competencies to be able to participate in those types of risk-based models. Number 7, again, is more on the burden on the state to get the job done, which is enhancing dual eligible enrollment in integrated plans like PACE or DSNP, for example, DSNP, excuse me, moving folks from traditional Medicare into these types of plans, which they believe better manage those high-cost conditions. And here, can the state make investments that will promote enrollment and maintaining participation in those plans going forward? Number 8 is adoption of remote care services in all of its form. And again, 50% point here because of the state policy provision. Developing a data infrastructure, so investments in EHR, AI, other clinical supports and software, noting here that whatever a state chooses to do needs to align with the CMS health technology ecosystem, that's a hard word for me, criteria. And finally, number 10, you never thought we'd get there, consumer-facing technology. So how can we use technology to help folks stay healthy and then manage their own conditions? There are some specific, for each of the initiatives that a state proposes, there's a very specific list of details that need to be included. You see these here on your screen, specifically calling attention to number 3, that each initiative has to have at least 4 quantifiable metrics so that you can evaluate the program's impact. CMS is going to evaluate the state's progress against those metrics to make future funding decisions. So you have to continue to perform and improve to receive out-year funding underneath this program. And of course, an emphasis on sustainability. I think kind of the analogy we've been using to explain the Rural Health Transformation Fund is that it's venture capital. It's the dollars now available to engage in transformative activities in your state, money you would not otherwise have as a startup for a new initiative. And then, of course, any venture capital fund wants to know, once you've used those startup monies, how will you sustain your business? Same is true with respect to these specific initiatives. The detail then on how the factors will be scored, don't want to, again, it's a level of detail in the application that how CMS will follow through. Basically, the answer is write a really good initiative, have an excellent work plan, identify who's doing what, how much it's going to cost, and how are you going to sustain it once the money's no longer available. There are a number of funding restrictions, so things you can't spend money on using these funds, and the one that's caught the most attention is no new construction, and they are absolute on this, no new construction. You can do some renovations and alterations, but you have to link those specifically to an initiative. An example would be sort of that right sizing. If you're going to convert to a rural emergency hospital, we know that you have to do some alterations to your facility to make that effective. That would be an example of where you could use the program funds for that purpose. You cannot use funds to pay for clinical goods and services that are otherwise reimbursable by a federal healthcare program. You can spend no more than 5% of the money that has been allocated to the state to replace an EMR system. You can do updates and upgrades, but the actual replacement of an EHR system, paying for a hospital to do that, that's capped at 5% of your total budget. The state can use 10% of the money to administer the program, and you have to identify in the initiative what's administration, what's programmatic, so that CMS can track whether you're exceeding that 10% cap. And then you cannot, interestingly, you cannot use the funds to pay for a clinician, their salary or wages at a facility that imposes a non-compete. So they said that's counterindicated in rural communities. And you see there again other restrictions going forward. CMS is very direct that it will be monitoring states for noncompliance with terms and conditions. There are significant reporting obligations on the states. Plus, CMS has plans for auditing state performance with respect to the achievement of milestones, as well as identifying noncompliance. You see on the screen the list of the types of noncompliance for which there will be monitoring. And then CMS specifically calls out the remedies that if they do identify noncompliance, there'll be a 90-day notice to correct the deficiency. And if you fail to remedy, it will mean both a clawback of prior funds as well as withholding future payments. So certainly as you build these programs, the states will want to make sure they have appropriate infrastructure in place to ensure compliance with these requirements. So that, Kathy, it's going to be interesting. It's we lived through the Provider Relief Fund, and this is significantly more money than went to states for went to rural providers for Provider Relief Funds. But that was all about replacing lost revenue and paying for additional incurred expenses. This is like the opposite of that, right?
And the money is not going to the providers.
I know, not directly. Not directly. Has to go to the states. Has to go to the states. And it has to be transformative. It can't simply be, filling the gap in lost Medicaid funding. That is a absolute. Every time CMS starts to talk about this program, it's like, we're not filling the gaps created by cuts to Medicaid. This is instead to transform rural health so it can survive those cuts and actually prosper going forward. So over to you.
And Martie, before I go into the issue of the nonprofit status and the hearings that have been held on that, took a look at a number of the questions that have been posted. I've tried to respond to some because of the issue of sequestration. Is it going to be 2 + 4? No, it's going to be 4. That is the max for Medicare. It is a 4% sequestration. Congress can stop this. They have done it in the past. The other question was, what's the effective date? And that really has to be established by Congress because they do have to take action on this. Currently, the 2% is effective through December 31st, if I remember correctly, of this year. So what we then are looking at is stepping in, and Congress, they have 14 days after the end of this session to say yay or nay and to establish a date. So happy holidays. Never mind, I didn't say that. Let's keep going on this. There have been several hearings in Congress related to essentially nonprofit status. The hearings that we have listed on the slide, I think the names are fairly ominous. The first in the House Judiciary Committee on Oversight, how leftist nonprofit networks exploit federal tax dollars to advance a radical agenda. I wouldn't be going into that session thinking this is going to be very positive. I mean, just gut feel. But
I'm sure several of our attendees are surprised to learn that they are radical leftists.
Yeah, absolutely. And that you're working a radical agenda, healthcare. And then in September, the hearing within House Ways and Means, virtue signaling and versus vital services. Both of these are available if you get really bored, particularly with the shutdown. If you get really bored and you want to go and see what, I've missed, federal agencies telling me what to do. Gives you an opportunity to go back in and listen to these. But essentially what we were looking at when we looked at these two hearings, essentially the focus is not on independent community hospitals or rural hospitals. It is on large not-for-profit healthcare systems. And the focus is on those entities, what they're doing with dollars as it relates to their nonprofit status and the other expenditures that they have. There is bipartisan support for increased transparency, more detailed reporting requirements. I think we're going to see some expansions to the various schedules that we fill out. I would say to you right now, your community benefits report really needs to be talking about what you're doing, particularly if you're a part of a large nonprofit system. The other area that they really kind of spent a good deal of time talking about this is the idea of rural reclassification. And the idea behind rural reclassification is that an urban hospital reclassifies to rural for certain reasons, but stays urban for others. We also had discussion, I believe this was in the House version of OBBA, related to dual classifications. But what we now have is rural reclassified hospitals. In 2017, there were 3. There are now 425. So again, we're excluding critical access hospitals out of this. So we're talking about hospitals paid under the prospective payment system. 425 of them have rural reclassification. You're able to use be reimbursed using a higher urban wage index. And then you are going to be able to enjoy certain benefits that rural hospitals have, such as the disproportionate share percentage to qualify for 340B and expanded GME slots. The DISH percentage for 340B is 11% for urban hospitals, 8% for rural hospitals. So you can see the benefit of that. The word that was used in this is these particular facilities are administratively rural. They are not in a rural facility. The 425 hospitals that are mentioned here represent about a third of all community hospital beds. So concerning in terms of where this is. The other issue that we need to keep an eye on, we've had a lot of discussion coming out of the American Hospital Association and the AMA, relates to a proposal, a new program that was announced by the president in early September, basically for $100,000 fee on every new petition for an H-1B visa. The concern is, I guess you got to start with the number of physicians who are practicing in the U.S., who are actually international medical graduates. We're looking at about a quarter of the physicians, 1 in every 4, is an international, a product of an international medical school. Concerned that we have a major shortage in clinicians right now, both physicians and nurses. So what happens here when we start imposing a fee for the H-1B visas? Current information from HRSA essentially says that by 2037, we're going to be short of over 187,000 physicians. So imposing a fee such as this, various concerns, not only in rural areas, but everywhere, because such a large volume of our physicians are not, they are coming into the country to provide care. Martie, comments on?
Well, I would just say, as the state's working on its rural health transformation plan and its workforce initiative, it may want to include money to pay for these visa fees, because that's who this is going to hit. Because the numbers you cite, Kathy, are exponentially greater, or percentage-wise greater, in rural areas.
Absolutely. If 1 in 4 nationally are a foreign trained, then what are we going to be dealing with when we are looking at a rural area? Significantly more.
Yeah, if you've never written a letter to your congressperson, here's your opportunity, which is to urge.
They are working.
Yeah, just to urge them to at least to make an exception for healthcare. I think this was, kind of, you read between the tea leaves, the real intention here was tech companies, and that they're not hiring Americans; they're instead getting these H-1B visas. But as often is the case, healthcare got swept into something that it wasn't intended to be swept into, and the impacts are negative.
And if you want to send a letter, recognize that the American Hospital Association and other entities have done this. You can go and pull down their letters and use those, but put in information related to your organization and the physicians who are taking care of patients within your community.
Tell your story. Right?
Yes.
Exactly. Let's wrap up on pharmaceutical tariffs because, let's see what's happened since we last talked about this. So where we are today, in July, you may recall the Trump administration announced a deal with the European Union that would cap tariffs on name brand pharmaceuticals at 15%. Generic drugs would not be subject to the tariff. And though we haven't actually seen this deal on paper, that's sort of where we're working from right now is the assumption of that tariff. However, then on July 31st, President Trump sent a letter to 17 manufacturers that gave them until September 30, yesterday, to comply with an executive order that had been issued in May, which said you drug companies need to extend most favored nation pricing to the United States, specifically federal healthcare programs. MFN means that there are other countries where these companies are selling drugs because we've nationalized healthcare, so they're selling them to the government at a significantly lower price than what they charge the United States. And President Trump argues that we're effectively subsidizing all of the research on these drugs because of the higher prices paid in the United States, and instead that burden needs to be borne more broadly. So that was the intention behind that letter. Then we get to September 25th, and we had the posting on True Social announcing that there'd be 100% tariffs on pharmaceutical companies that do not have buildings in the United States, and noting that it's an incentive to start building is the intention behind this. So if you are building a facility in the United States, you would not be subject to these high tariffs, but otherwise exclusively foreign manufacturers would be subject to this higher tariff. And then yesterday, because there's not enough going on, we had the announcement from Pfizer and the Trump administration in response to the July 31 letter. And Pfizer said it was agreeing to most favored nation pricing for Medicaid in exchange for tariff relief. And note here a couple of things. It's Medicaid, which is about a third of the spend as Medicare. So you certainly want Pfizer to extend this to the Medicare program as well as Medicaid programs. And then also appreciate MFN is still the list price. And when we talk about giving the same costs that charging the same amount that you would charge to another facility, that in fact it's exclusive of discounts as well. As part of this announcement with Pfizer about its decision, we also had the announcement of TrumpRx.gov, which is going to be a website where individuals can go online, look for a prescription, and they'll be directed to pharmaceutical companies' direct-to-consumer web pages to fulfill the order. Pfizer is committed to include certain drugs on its direct-to-consumer website. So this is intended to launch in 2026. I'm wishing it all the best because it'd be wonderful to have such an opportunity to purchase discounted drugs. So that's all we got for you today. We are going to have, this may happen. This may change, Kathy, because we did this slide before we knew the government was shutting down, because we are anticipating that the outpatient prospective payment rule will be published, as it usually is, in late October, early November. Assuming we have a rule, we will delve into the final rule on November 15th. So with
November 12th.
November 12th, that's what she meant to say, exactly.
Yes.
Hey, so back to you, Jennifer, to wrap us up.
Thank you for listening to this PYA webinar recast. The video recording, slides, and associated material for this and all PYA webinars are available on our website. If you have any questions or if we can help, please contact us at pyapc.com. Thank you again for joining us and have a great rest of your day.